Hi, my name is Dr. Karen Semmens. I am part of the Dakota Geriatrics Workforce Enhancement Program. Along with Dr. Chris Hendricks, we have developed a series of micro-lectures on the age-friendly concept of the 4Ms. The 4Ms being the mind, medication, mobility, and what matters. This presentation is focused on the mind. This presentation's title is called Overview of the 3Ds: Dementia, Delirium, and Depression. Our objectives for this presentation are to identify the 4 common types of dementia, understand the differences between dementia and delirium, understand atypical depression as it relates to dementia, and recognize various diagnostic measures that we utilize in diagnosing dementia. This slide shows a picture of an umbrella. Dementia is an umbrella term for the 4 most common types of dementia, and you'll see those on the slide: Alzheimer's, vascular dementia, Lewy body dementia, and frontotemporal dementia. Each of those will be discussed in further lectures in more detail. Dementia versus Alzheimer's. How does dementia differ from Alzheimer's? Dementia is not a disease. Rather, it's a general term for forgetfulness that interferes with daily life activities. Alzheimer's is a progressive disease that affects various parts of the brain. Some statistics for Alzheimer's and dementia. Alzheimer's is the most common and well-known type of dementia. In 2022, there was an estimated 6.5 million Americans that are over 65 that are living with some type of dementia. That is estimated to rise to 13 million by 2050. Because Alzheimer's is a disease of the aging, and as is dementia, 1 in 9 persons over 65 have Alzheimer's. 2 out of 3 of those with Alzheimer's are women, which would make sense because women tend to live longer. There are 11 million Americans that provide care to someone in their family with dementia. Not a lot of people that are elderly are living in nursing homes or long-term care facilities. Many of them are still living in their own homes or with family members. With normal aging, there is some forgetfulness that does go along with normal aging. Just because there is some forgetfulness doesn't mean the person's going to have dementia. As we age, we can continue to perform our basic ADLs. Our basic ADLs are bathing, dressing, and grooming without needing any assistance. Sometimes we have difficulty performing our IADLs, and IADLs is independent activities of daily living, which is being able to pay your bills, driving to the grocery store, knowing how to get from one place to another, answering the telephone, basic day-to-day things. So with dementia, sometimes we have an inability to perform our IADLs. That will typically precede the inability to perform our basic ADLs. So it's with somebody who has dementia, you're going to see they're going to have more trouble answering the telephone, more trouble running the remote for their TV, for maybe forgetting to pay their bills. They'll have more trouble with that than they would have trouble with bathing, dressing, or grooming. There's also going to maybe be an inability to manage finances. That might be one of the earlier IADL changes that can be suggestive of cognitive decline, such as balancing the checkbook. We do become a little more forgetful as we age. Remember, just because we're forgetful doesn't mean we have dementia. They might need a little longer to remember things, and we might get distracted easier. And sometimes we do forget to pay our bills. Just because we have these things going on doesn't necessarily mean we have dementia. So here's normal aging versus dementia. With normal aging, sometimes we make a bad decision once in a while. With dementia, that person might make bad decisions a lot of the time. Normal aging, we might forget what day it is, and we might remember it later. With dementia, we lose track of the date and time, and we don't remember what it is. Sometimes with normal aging, we forget what word we're going to use. With dementia, it's just difficulty having a basic conversation. With normal aging, we might lose things from time to time, but we'll find them later. With dementia, there are items that are misplaced, but they're not able to find them later on. Another D that we want to talk about is delirium. Delirium is not dementia. Delirium is worsening or changing in a person's mental status that happens suddenly over 1 or 2 days. You do not get dementia overnight. Some of the causes of delirium can be dehydration and malnutrition. These can be very common in an elderly person, especially the malnutrition if they're living on a fixed income. If you only have $10 to spend and you need to buy yourself some meals, it's going to be easier or better. They might think it's better that they buy 10 packages of ramen noodles versus buying some healthy choice meals. Medications can cause delirium. Too much medication, not enough medication, taking their medications at the wrong time. Sometimes with medication, we might want to think about anesthetics. If a person's having surgery, sometimes it takes a while for an elderly person to be able to clear that anesthesia from their brain, and that can cause some delirium. Infections also cause delirium in an elderly person. One of the main types of infections that we think about are urinary tract infections. We might notice that mom was doing fine yesterday, but today she's really confused. We check to see if she has a urinary tract infection, see if she has any other type of infection. The other D we want to talk about is atypical depression. Atypical depression is what is often seen in someone with dementia. It's not the typical withdrawing that we normally see from somebody with depression. It's more anger-based. The person might become annoyed very easily, agitated, become a little bit more aggressive, possibly could have some increased anxiety. To diagnose dementia, it is very challenging. It is important to get the proper diagnosis so that we're treating the right thing. We need to recognize that the pattern of loss and the skill of the individual is experiencing has changed. We review medical history. We also want to review family history. Talk to the family to see, when did you start noticing that your parent or loved one was having problems with memory loss? How long ago was it that they started to seem to have some trouble? Is there a family history of somebody else in the family that might have some dementia? There is not one single test that can diagnose dementia. Some of the testing that we do want to do are some cognitive and neuropsychological tests, such as maybe you've heard of the mini mental status exam. Tests that the mini cog is another one, but these tests will test the person's thinking ability. Can they recall words that we give them during the test? What is their reasoning and judgment? How about their language skills? Can they pay attention during the test to answer the questions that are asked? Also, there's a neurological evaluation that will test their memory, their language, their visual perception. Can they identify what is being shown to them? Again, can they pay attention? What is their ability to solve problems? Do they have any movement issues? Do they have problems with their senses? Do they have trouble with their balance? And do they have any trouble with their reflexes? All of those are some parts of the neurological evaluation that should be done. We also might have to do some brain scans, maybe do a CAT scan or an MRI to see if there's an evidence of a stroke. Is there a bleeding? Is there a tumor or hydrocephalus, meaning an enlarged brain or fluid in the brain? Has the person had a fall and is causing some bleeding in the brain? A PET scan, which is a little bit more advanced than a CT scan or MRI. This will show some brain activity. This could possibly also show some of the deposits of these proteins that indicate a possible Alzheimer's disease. Laboratory tests that should be done to rule out any other organic or medical disorder would be thyroid tests, vitamin B12, electrolytes such as potassium and sodium, their BUN and creatinine when they check their urine, and folic acid. Oftentimes, a person who has an upcoming dementia or dementia that you're not sure exactly where it's coming from or what it is, might get you might have a psychiatric evaluation. We want to check for depression. We want to check for anxiety. There is a type of dementia that is often misdiagnosed because they might think the person has schizophrenia because that type of dementia, they do have hallucinations. So to wrap this up, we do have a case study. So here's our case study. You are working in an emergency room department as an unlicensed assisted personnel. A 79-year-old female, Dorothy, came in by ambulance due to a fall. She fell in her bedroom as she was on the way to the bathroom. Her daughter reported that her mother did not hit her head, but landed on her knees, and they want to be sure that nothing is broken. The daughter also stated that her mom has not been herself these past couple of days. Dorothy is moaning and holding her right knee. She does not know where she is. When you asked her if she knew where she was, she said she was at her daughter's house. So here's some questions regarding that case study. What would you report to the nurse? You might want to report that the person had a fall, that they're hanging onto their right knee, that she's been having some not quite been herself in the last couple days. So do we think that the person has dementia, or do we think the person has delirium? How do you tell the difference between dementia and delirium? Well, we don't want to make a rush diagnosis. We want to think that, ask the family members, how long has she been not quite herself? Has she had some memory problems in the last month or the last 6 months or the last year? Or is this just something new that has come on? And for Dorothy, we might think that she is having delirium. She's fallen. She was on her way to the bathroom. Maybe she has a urinary tract infection. She couldn't get to the bathroom on time. Sometimes with a urinary tract infection, you might feel that more urgency to have to go to the bathroom. So we might think that she might have delirium versus dementia. Oftentimes what happens is when an elderly person comes into the emergency room and the family is stating that the person has some confusion, they automatically get a diagnosis of dementia without running the full battery of tests that we have talked about earlier. So it is very important to make sure that they get the right diagnosis and don't end up with a diagnosis of dementia, because that is very difficult to take off of their chart. What kind of safety precautions would we like to implement for Dorothy? We want to make sure she always has her call light in place, that the bed is in a low position. If she is a little bit confused and needs to get up and use the bathroom, make sure that she has a sitter next to her, or maybe her daughter can stay with her. Making sure that there's maybe a commode next to her so that she doesn't feel like she has to get up and walk. She does have a sore knee. So those are just some of the things that we want to think about regarding our case study. These are our references for this presentation. Thank you very much for participating and listening, and we will see you in further future presentations. Thank you.